Today I'll be explaining you about the excision or decompression of spinal cord tumors. So there are so many types of spinal cord tumors that we see regularly in our OP on a daily basis. So what are spinal cord tumors? This is the cord and it is surrounded by a fluid which is called as cerebrospinal fluid. Around this is a very thin covering which is known as dura. So many of the spinal cord tumors, they arise inside this dura and compress the spinal cord. Many tumors, they arise outside the dura and ultimately they grow in size and compress the spinal cord. Depending on where these spinal cord tumors are present, say in the cervical spine, in the dorsal spine or the lumbar spine, they can develop a range of symptoms in the patient. For example, if the C-spine is involved, it can lead to neck pain, hand pain, tingling, numbness, tightness in the legs, difficulty walking. In very rare cases, it can lead to weakness of all the four limbs also, which is known as quadriparesis. If they are in the dorsal region, that is the mid-spine, they can lead to tight band-like sensation around the stomach. Again, urine motion issues, again tightness in the limbs, difficulty walking, paresthesia, tingling, numbness, back pain, and sometimes even complete paralysis of both the limbs. These tumors can also be found in the lower back, that is the lumbar spine. Like any other surgery, the spinal cord tumor excision is also a very critical neurosurgery, and in most of the cases, we make use of a special equipment which is called as neuromonitoring, so that during the surgery, we can safeguard the patient. We can protect the nerves and the spinal cord before any permanent damage happens. So, like I had explained in the pre-operative workup, after the pre-operative workup is done, once the patient is placed under general anesthesia, as per the site of the tumor, mostly we'll have to turn the patient on the stomach, locate where the tumor is, clean that area, open it, go inside, remove as much as tumor as possible. In so many cases, we are able to remove 100% of tumor. In some of the cases, we are not able to remove 100% of the tumor. It is only decompression of the spinal cord. Post decompression of the tumor, whatever tissue that is available with us, we'll be sending it to histopathology to confirm the diagnosis. So, once the excision or decompression of the tumor is done, we will get the patient out of ventilator support, assess all his functions, whether he is moving his limbs and the hands according to the site of tumor, whether it is in cervical spine, dorsal spine or lumbar spine. In rare cases where we feel that the patient needs ICU stay, 1 or 2 days ICU stay might be required. As explained on the first day of surgery, no food, no water. We will wait for the patient to pass some flatus. On the day 1 after surgery, once patient starts passing flatus, we will give some liquid. After the patient passes some stools, on day 2 of the surgery, we will be giving soft tide, and if possible, if there are no pre-existing urinary issues, then we might also remove the urine pipe. After a few days, maybe 3 to 5 days or sometimes 7 days, whatever drain that we have placed inside the body to collect waste blood, that will be removed and we'll be discharging the patient. 10 days post-discharge, the patient will come for review, where if the wound has healed well, we will be removing the sutures. So in like most spine cases, definitely there can be 1 to 10% of various complications that can occur during this surgery. First and foremost is bleeding. Any surgery can lead to some amount of risk of bleeding, and we might need blood transfusion if there is major bleeding. Second is infection. We are going into the spine and doing the surgery. Surgical site infection, wound infection, in rare cases, spine infection also can be present. If there is any CSF leak, we might have to do regular suturings. There can be delayed wound healing, delayed suture removal, and it can happen in 2 to 5% of cases. Also, the drain might have to be kept for a prolonged period of time, at least 7 days, 5 to 7 days, post which we can discharge the patient. If the patient is already having some recurrent pre-operative bowel bladder function issues, These can get aggravated post-surgery. There can be need for prolonged catheterization post-surgery if the patient already has some pre-existing urinary issues. After the surgery, we want to get the patient out of ventilator support, but in some cases, when the patient is not able to breathe, we might have to shift him on ventilator support into the ICU, and this can happen in 1% of cases. Definitely, any surgery under general anesthesia is a stress to the body, to the heart, to the lungs, to the kidney. Also, if pre-operatively, if the patient has some constipation or diarrhea issues, post-surgery it can get aggravated in 1 to 2% of cases, and it is known as post-operative paralytic ileus. So, in the post-operative care, once the patient gets discharged, if pre-operatively patient has any neurological deficits, say he is not able to move the hands or he is not able to move the legs, in that case, post-operatively, the patient might need long-term rehabilitation care. In the rehabilitation centers, the doctors, the nurses, they will be taking care of the physiotherapy. So many patients before surgery only, they are bedridden because of sudden neurological deficits. So they might require post-operative long-term rehabilitation center and rehabilitation care. In any neurosurgery procedure, the aim is always to prevent further deterioration and to prevent further deficits. Whatever weakness and deficits the patient has already developed, post-surgery, once the patient recovers from the surgery, we need to try to improve with physiotherapy. But there is no guarantee that all those symptoms might get reversed. Thank you.